to order. It's 12:05. I want to start out by thanking everyone for their attendance today. I appreciate you being here. And as stated prior, thank you, Ms. Lester, for arranging lunch. Thank you to NGH staff for creating this wonderful buffet we have behind us. As Mr. Escobar said, we also have Cheerios. So thank you, most importantly, for the dessert and the opportunity to partake. We'll start with a conflict of interest, an opportunity to disclose. Anybody has a conflict of interest to disclose? Seeing none, the next item on the agenda is a mission statement. Mr. Lesser, would you like to read that?
To improve the health and wellness of Nashville, excuse me, by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice.
Thank you. Public comment? No one? Okay. Next up is the minutes. Everybody's had a chance to review the minutes of the May 29th, 2025 meeting. Any adjustments we need to make? Seeing none, we'll entertain a motion to approve.
Moved.
Is there a second?
Second.
Any discussion? All in favor?
Aye.
Aye. Motion passes. No old business. We'll move to new business, which is the fiscal year 26 CEO objectives. As stated in our last board meeting, the goal for this committee is to have these CEO objectives ready prior to July 1st, so that any CEO going forward from a precedent standpoint has their goals and objectives and a full fiscal year to obtain those. So with that goal in mind, this committee had decided to go ahead, even with being in an interim CEO situation, to go ahead, work on the fiscal year 26 goals and get those approved. We'll move to full board for approval. So that is the impetus of this meeting, is to continue that process, setting precedents that we're on time going forward. So you should have received in your packet the draft of the CEO annual performance assessment form, and this has been modified some and hopes to achieve the most updated objectives in the 5 key areas. So would like to also welcome Dr. Elders to our meeting, who is our interim CEO. As a recommendation from our board meeting, someone had asked that she weigh in and be a part of the process, since she has a great oversight at this point of where the hospital is and ways that we can move forward. Understanding that a couple items. One, we will be going through the RFP process. So at some point within the next fiscal year, we may have a sitting, and most likely we'll have a sitting full-time CEO. The second would be that we are in the process of doing a financial analysis with KPMG. I met with them prior to coming in, being the finance chair, and working with them on the outcomes, what the goals are and the findings, and then I think those will help continue to direct these these objectives. So knowing that that's out there, and hopefully with Dr. Elders being an integral part of those conversations, she has the ability to weigh in as well. So that being said, we'll go ahead and get started with each of the key areas and just walk through the bullet points. And committee members, Dr. Elders, if you'd like to weigh in on some of these as to where we stand in terms of both the goal and objective, but also most importantly, the measurement criteria, because that is what you would be based on as either, the CEO at the time. So first goal and objective is to increase market penetration to all areas of Davidson County. So, that's north. I specifically denoted this, but north, south, east, west, and downtown. I don't know that we have to put the geographic areas in there, but I think it's important to say all areas of Davidson County, because I think we've discussed in this committee, there's been a real focus on certain areas of Davidson County without really having a marketing plan and goal of growth for all of Nashville. Are we okay with that? Okay. Secondly, exceed projection numbers for hospital and all clinics. We put this in here, I'm assuming this is the criteria that we receive on the financial statements that talks about, visits, actual visits to the hospital and the clinics. And so I think at the end of the year, we can look at, and if we wanted to, that will be a specific number, and then look at that with regard to increasing that, and we can see that in the measurement criteria. Are we comfortable with that as a growth criteria? I feel like that's a fair metric, as meaning more people through the door, more beds, heads in the beds, if you will. Okay.
Madam Chairman?
Yes, sir. Dr. Martin.
In another company that I was involved in where we had growth criteria, we had graded points awarded. If you grew by 2%, let's say that this constituted 5% of potential bonus. Mm-hmm. So if you didn't grow at all, it was 0. If you 0 to 2%, 2 to 4, etc. So that you had grades of award for things for which you had really metrical information. Just a suggestion.
I think it's a great suggestion, and several meetings ago, meaning probably, I don't know, a year ago, we did look at other CEO evaluation techniques, one of those being the BNA, and they do use that type of metric and grading system. So I think the goal was to, first and foremost, get caught up, which we have been able to do, and then secondly, get to the point where the metrics are in alignment with what we feel like the goals for the hospital are, which I think we're there with that. And then the third thing is, to your point, like, how do we continue to refine the process and the points to where that gives a very specific, measurable, and then it's not a yes or no. It's you made 80% a goal, 100% a goal, or let's say 120% a goal, and then those would align with what percentage point value that ultimately comprise growth categories. So that way we're not saying, well, you didn't meet the numbers, so you get a 0. If you met them, but only at a certain percentage growth, then there seems to be a little bit more flexibility. It allows you to also, to me, have a realistic but also a stretch goal in some of those. And people are more comfortable, I think, with that mentality of having a stretch rather than something more comfortable where I just don't meet that goal. Yes, Dr. Elders.
Thank you, Madam Chair. I do think, and I like the graded approach, because one, just being intricately involved in the hospital and its operations at current state, if this is for FY 2026, a 15% overall growth prior year end may be a very stretched goal. And so I think the weighted percentages might be more beneficial to the person that's coming into this seat.
And let's jump down there because I'd like further input on the measurement criteria as well. But I completely agree with that. Cerner, no, you're all good. Cerner fully implemented. And functional. That's done, isn't it, Dr. Elders?
My question would be, what does that mean to the board? Fully functional. There are aspects of Cerner that, from a data standpoint, that we still are having difficulty obtaining clear processes for, which has been revealed in the KPMG audit. So I think we need to define, as I look at the measurement criteria, what does fully implemented mean? What does that mean to the board in regards to grading?
I think that's a good point. Right now, it is very vague. Just speaking as one board member, what I would like to see there is that fully implemented means that the provision of data, like the mechanics of Cerner, are done. Because I think we were getting some updates that we were requiring a lot of additional time to just complete the process. So to the extent that's not done. And then the second component of fully, if we were to specify, would be using the additional tools that Cerner was giving us to their highest benefit. I think it's an important objective for the CEO to, and the interim CEO, while we don't have a CEO, to have as an objective, performance objective, making sure that that investment is paying dividends in terms of how we're using it. So I would define fully implemented those two ways.
Madam Chair, I'm not a member of this committee, but a member of the board. I think that's a dated criteria. I think that we had a goal in the last year of implementing Cerner. There were a lot of challenges. I think we've kind of met that goal, unless there's some big benchmarks like extending it to the clinics or something like that. I don't think that really should be a big part of her evaluation, of the CEO's evaluation.
Yeah, I think most of Cerner is done. The other aspects may take much longer, like interoperability and how to connect the clinics outside the hospital in real time, or how physicians have the capability to respond, assign charts with their cell phones, and that would take time and more investment. But I think it's pretty much done.
Okay. Again, this is great to have these conversations. I mean, you as a practitioner and someone who's engaged in that every day, that's not what I do every day. So I think it's very helpful to have people who are using it. And ultimately, the roll-up of that is to, and I think, nurses have been on board, physicians are slowly getting on board with some of that. But the goal would be, how does that, to me, push back to growth? Now, to me, that's efficiencies. If people are using it, if all physicians are using it and using it efficiently and accurately, then that helps ultimately create more space and time to allow them to see more patients. It helps with growth, but it still needs to tie back to growth. But if we feel like it's a criteria, or better yet, if there's another criteria that makes more sense, let's roll with that. Again, these are not hard and fast. That's the reason we're here, to kind of talk through them. And we have a great diverse committee, and obviously kind board members who are willing to share their thoughts too. So happy to remove that one.
I'm okay taking it out if Dr. Eldridge is okay and the will of it. I will say that the reason why I thought it made sense, and maybe it can be something else, or it doesn't have to be this, it may be enveloped in other things, is that a certain frustration as a board member that so far the only report I've gotten from Cerner is that it has cost more money than we thought, and that while we're implementing it, we're actually seeing fewer patients because we've had to transition the clinical to adapt to this new system. So I'm hoping that at some point there will be a report to the board, which is, we've invested a lot of money, we've invested a lot of time, we've sacrificed seeing patients in order to adjust to a new system. And the reason we did it is because now it's starting to pay dividends. And if we don't get a report like that, I will wonder, why did we do this? Because so far it is all, I mean, I hate to be so blunt about it, but there's never been a positive report about Cerner to this point.
Yes, sir, I understand.
Sorry.
No,
Too blunt.
yeah, no, it's all good. But that's why when you look at the measurement criteria, my question back to the board was, what does that mean to you in regards to that measurement? It can mean many different things. I think to your point, Mr. Escobar, I agree, and I've certainly heard that feedback from others in regards to our Cerner report. So what is it that the board is needing to see for the person that's sitting in the seat to meet this goal or objective is kind of what we need to decipher out. I agree with you in regards to your sentiments. And I like blunt. I'm blunt as well.
Does it make sense to talk about not just Cerner, but all technology at a higher level in terms of, and again, this is why we're so glad you're with us, but, and this is not something we have to nail down today. I just wanted to make sure we got close to the July deadline. But does it make sense to talk about technology in a way that allows for efficiency and to categorize within growth? Is that the appropriate place that it sits and lives? So just, are there other things that help drive that growth for the hospital at a level that would be appropriate for a CEO to be evaluated on? So,
I think definitely growth is a major need for the organization. So I think growth in patient revenue, growth in number of patients seen within the hospital and the clinics. That's an easy parameter to measure.
Madam Chair, you brought up something a few minutes ago that I think may be relevant here as well, and I understand the Cerner issue may be just ongoing at this point. There are always going to be little things going on with Cerner, but you raised the point of technology, and I'm not sure anywhere in our assessment we talk about technology, and technology is a very, very important of any kind of business, including a healthcare business. So maybe we ought to be thinking about where and how we insert a reference to a making sure that we are leading to the extent financially capable of engaging in the best technology to provide the best care for our patients.
That's a great idea,
yeah.
but we can even extend it and say innovations. So the CEO can always lead innovations. I know, for example, Dr. Elders has been integral to the no-wait ED. I mean, that's something that promotes growth, promotes quality, but it's an innovation. So you choosing innovation rather than technology
You can have both.
implies yeah, you can have both, but innovation for the most part also promotes growth in a big way. Whereas I give an example with this hospital, we bought robots for lots of money. It took close to 2 years before we did cases with them. That's technology, good technology, but it didn't enhance growth. Now we're using the robots. So again, innovation is the one that gets you more bang for your bucks. But we got the technology of the robots, but it took 2 years before we got people trained. And we were paying monthly charges on those robots. That's just an example of how you can get technology. It costs a lot of money, but it doesn't impact your bottom line, whereas innovation always does.
But it's not impacting your bottom line in the near future, but it has a long-term potential. Then that is why we do the technology, not only for what it does literally from a healthcare perspective, but from a cost savings and efficiency perspective. So I would prefer that we not look at things based on necessarily exclusion to what it does to our annual revenue base.
Okay, that makes sense.
So, and I'm taking notes so we can, again, send it to Ms. Lester, have her distribute in areas that we think these categories. And again, we may, as we refine the goals, so remember, here's a strategic idea. How do we measure that? So I think that to me, when we talk about innovations, we talk about technology, and if we put it under the category of growth, how do we create a measurement tool? And again, it doesn't have to be exactly a number, but we need to be able to point to something and say this CEO excelled in this area because of they hit these measurement criteria. So, but I did put that down. So the measurement criteria to achieve the market penetration as well as exceeding the projected numbers, and maybe the numbers or visits or something we probably should specify, not just numbers. What that number means, but I think it's here. Increased participation in community events and speaking engagements amongst all of Nashville. one of the best practices I saw was that was actually part of a slide. And I think Dr. Elders has done this to some degree within her board packet to say, these are the things I've been doing. But I do think that that's helpful for us as a board to see the visibility and activity in the community of our CEO. Increase the number of patients seen at all clinics and hospital by 15%. This is the, I think our growth numbers that Dr. Blackledge used was, 2%? So we probably need to I put beside that question mark reasonable. So maybe we refine that to those three areas mentioned by Dr. Martin, which is, this is achievable and these are more stretch goals. And we can work with you and Dr. Blackledge to help figure out what that is if, 15% is not the right number. We talked about Cerner, healthcare community. This was brought up as well, which is attending the relevant healthcare industry meetings and, again, cascading those findings to the board and the team in terms of growth of, to me, knowledge and growth in spreading that knowledge and best practices down to the organization as a whole. Any other measurement criteria or any amendments or deletions to those criteria?
I'd just like to second what I think was a place we were getting to on the goals and objectives, not on measurement criteria, but to replace Cerner specifically with technology and innovation. I like that phrasing of having the CEO have as an objective, because it encompasses Cerner, but it also encompasses other things, which is how are we using technology and innovation in order to expand our reach.
Okay, moving on to financial leadership. Goals and objectives are accurately and timely meeting budget goals, reducing expenses and service lines not meeting goals, increase net patient revenue, decrease accounts payable delays, and timely collection of accounts receivables. All of which are being addressed and worked on right now by KPMG, and I will tell you that I'm very pleased to hear at least the work that's been done and the findings. The measurement criteria currently are having an unmodified opinion for the prior year audit, the audit finalized by 10/31, and the reason that date's in there for some of you newer members is because the director of finance for Metro would like to have it done by that time so it syncs up with their ability to file a timely response from their audit perspective. So last year we were delayed, which then delayed Metro, and we just don't want that to happen again. So they gave me a date of 10/31 that would work for their schedule. All material weaknesses and significant deficiencies have been cured from the audit the last 2 years. So because the audit is always done after the fact, that's the reason that there's a delay in, so it's not a current year item. I did work with Crossland, our auditor, on some of the language and specifics to make sure I got the language correct, but we'll make sure that we run it through KPMG as well. A reduction of days of delay on accounts payable to 60 or less. As many of you saw in our financial statements, we've regularly run above that. My understanding is our goal should be probably closer to 45 once everything is paid up, accurate, and the lines of business are reporting appropriately and categorizing things. At this point, that's a far stretch from where we're at, so that probably should be revised. Again, that is an area where we could categorize a stretch goal. So, in speaking with Dr. Elders, Dr. Blackledge, I feel like a 90-day window is probably a more accurate representation, and even maybe a little bit of a stretch at this point. I don't know. Dr. Elders, you want to address that?
Yes, ma'am, I can. We have met, and you all will get an update from KPMG tomorrow at the board meeting, and you can see, and it'll demonstrate exactly the difficulty that we are in current state with our financial reporting. So when I'm looking at this, and this is a goal for FY 2026, what I shared with Ms. Smith is that there's not anybody that's probably going to be able to catch this up to 60 days without a large input of cash. I'll be honest. So even 90 days is a stretch, but that's where we are shooting to get to for this fiscal year. But it would be really hard to do considering the deficit that we'll be entering into FY 2026 with, and then the continued work on our financial infrastructure that will go on through August.
So it seems to me that this particular measurement and virtually all of the others end up being pass-fail. That you either accomplished it or you didn't. That maybe there's a numerical affiliation with it somehow for further investigation, but as it stands right now, as I go through all of these, including the one that Dr. Elders is referencing, you either accomplish it or you don't, the way it stands.
And we can, yeah, no, and again, these are just drafts, so we can change that to 90 if you feel like that's a more appropriate measure. But the other option is to put more broad language to say a significant reduction in or a reduction of those days, so it's not a hard, fast number. So I think that's to your point. That's what you're stating, right?
There is some flexibility in the way we've devised this, which is we are ranking these things from 1 to 5. So I, as a reviewer, might say, if you were this close but you didn't achieve it, maybe that's a 3. And as we've done these meetings before, that would result in awarding a bonus under the, if one of the purposes of this has been in the past compensation, and if it's still that, it would leave room. I agree with you. It is written down as a all or nothing, but superimposed on that is this 1 to 5 scale that we assign to it.
Yeah, I'm still not comfortable with it, but I'll go along with what the committee.
Can I make a suggestion, only because I've watched this process several times in the past? If we take out the days, so if you say reduction of days of delay on accounts payable, and then as to Mr. Escobar's point, you're rated a 1 to 5, the CEO always completes a self-evaluation, which at that time they should be able to tell the board, we've reduced the delay on accounts payable from this to this within this fiscal year, and you all rate between 1 to 5 on what you feel like is achievable. It's just a thought.
Well, it sounds like that would accommodate Mr. Lester. It sounds like that's what you're suggesting, which I agree with that sort of structure.
That works.
Okay, great. Next is exceed budgeted net income without extra unplanned city subsidy.
Once again, I find myself repeating what I said before. In this case, I don't know a lot about finance and accounting, but what my experience tells me is I could easily manipulate numbers to suggest that I exceed the budget net income by $1, and therefore I have succeeded here. Now, again, we could go to the 1 through 5, but I think it would be great to be clearer about in the definition of the measurement criteria so that we don't have to question that at a later date.
Are we looking at more of a balanced budget type mentality at that point, or is that what you're thinking? Changing the language?
I'm not sure I was counting on the financial whiz at the chair of this meeting to come up with that response.
And this is something too that I want to make sure that we partner with Dr. Blackledge as well. I didn't want to bring every ELT in, which has been done in the past. I have him sit through 40% of the meeting that doesn't involve them. But that's the purpose of this meeting, to say, you know, should we amend this language? If so, who do I need to go see about making sure that the language meets what we want as a committee with this category, but also is directly defined by what they're doing day to day as well.
Well, let me kind of go back to what Counselor Esquivel suggested, in that, well, I almost called you doctor as well, yeah. In that this is for this year, and I think we're going to be a lot smarter going into the next cycle that will help us refine this to be a little bit more focused than we might be in this initial, keeping in mind that we've come a long way from where we were 2 and 3 years behind. And so at least we're looking at, it's not July 1st yet, but we're darn close. But I think I can be comfortable if we understand that we're going to leave ourselves open to further refinement in the next cycle.
Yeah, I think that this always should be looked at. I mean, every year, it doesn't need to be a set it and forget it mentality, because the hospital hopefully continues to evolve in such a positive way that we need to continue to push ourselves, which you mentioned regularly in our quality reports. I think, you know, I've seen that in other boards I've sat on, the CEO metrics every year continue to evolve. And I mean, some of them are very precise and detailed, but I think, like with any business plan, the more precise you can be, and then that drives behavior. And then that helps the ELT lead theirs. And so everybody funnels up, right? So the goals for each line of business are driven from these individual goals and objectives and the measurement criteria. And so it makes it very clear. This is ultimately the blueprint by which the CEO, you know, sets a vision for the hospital year over year, I think. So that should be in every meeting, to say, how are we this month achieving these goals? Are we on track? Are we not? If not, where do we need to amend? But yes, absolutely. And now I'll get with Dr. Blackledge on that particular bullet point, and then obviously the financial leadership category as a whole.
Madam Chair, would it be helpful for us as a board, once we approve all of this and get that to the board, that maybe 6 months from now, we just do kind of an overall review at this level, and then even at the board level, just to see how this is going, not necessarily to change any of it at that point, but to just kind of do a checkup, if you will.
Yeah, I mean, I think we're going to, the answer is yes, happy to do whatever the committee asks for and it feels is appropriate. I do think we're going to be revisiting this in general once the CEO is actually selected as well. I do think that, as I've stated before, that, you know, if I am the person interviewing for that job, I want to understand the metrics by which I'm evaluated. I want to understand the compensation structure and bonus, and then I want to understand the goals as written, so I know which direction day one I'm going to take the hospital and what I'm going to focus on. What are my critical few objectives that I need to hit, and how am I measured on those? If it's not a equal kind of proration, if you will, for the time I start, then how does that work? So I think we absolutely need to do that and stay on top of it.
And I agree with everything you've said. I think sometimes without a particular reference, and not necessarily to go through each and every one of these, but to make sure that in a 6-month period, the last thing I think we ever want to do is surprise anybody at the end of the year and say, well, you know, things aren't going quite as well in this category. Maybe we need to punch that up a little bit. Just to have a broad overview, not to spend 3 hours going through the details, but to have this in front of us and have a logical, rational, transparent discussion with the CEO saying, how are we doing? How are we coming along here? it doesn't have to have exact numbers, but to have a sense that we're moving in the right direction, rather than at the 11-month period, some things, and we'll know some of that from some of the monthly reports, but I'd like to align it with this on maybe a more formal basis.
If I may, because I will say I did read this prior to this meeting, but now listening to the concerns of the board, and then also sitting in the interim seat and thinking about the person who would have to look at this and actually meet these measurements, I would really want to know what is required of me to get a 5. What is that defined by the board? What does a 5 look like to you? Because what a 5 looks like to you, which you've seen in the past previous evaluations, what a 5 looks like to you may not be what a 5 looks like to that person that's sitting in this seat. And especially coming in being new, a new CEO, what does that look like? And so I appreciate getting the input from Dr. Blackledge, because I did look at it and I wrote a note. And only because on the goals of objective, the audit's not mentioned, but it's mentioned in the criteria. It's a big deal for us. But I also, even in all of these, now that I'm looking at it and listening to you all, what does a 5 look like to you as a board? You set the strategic plan for the organization. So what's a 1 look like? What's a 5 look like? So I think that weighted criteria is very kind of important. You don't have to be very specific, but I need to know what you need to get a 3. Like, what does a 3 look like? Wouldn't you? I mean, that's just something that any of us would want to know at an organization if we're being rated and evaluated. That would just be my suggestion. Thank you, Madam Chair.
Yeah, I mean, what they have, again, building off the past, doesn't mean we have to move this forward. 1 was unacceptable, 2's needs improvements, 3's average, 4's exceeds, and 5 is consistently exceeds, as stated by the criteria. But I understand that that doesn't always translate into, are you exceeding if, or are you consistently exceeding if, yeah.
I think while we have notes from the past, if we also wanted to build it for the future, it'd be nice to also look at how other public hospitals like Grady assess their CEO, or Jackson Memorial, or Pennsylvania Hospital, or Bellevue. How do they assess their CEO? And borrow from some of them. That way we can say, hey, this is what other public hospitals do.
I think it's very fair, and I'll be more than happy to work on trying to obtain that data for the committee. Yeah. Okay, so we talked a little bit about we were talking about the increasing net patient revenue. That was one of the criteria that I think we added in the past. I wasn't sure if we wanted to add a percentage, and then again, we can keep it more general as we've talked about as before, at least for this year. Remain with a 90-day positive cash flow monthly. I had a question mark, is this at this point realistic? Because that's not where we're currently at. So don't know if we want to amend that, take it out. What do we think is reasonable there? And then budget goals and regular meetings for each ELT member. Basically, the feedback I got from ELT was that they, in the past, did not actually have a budget. The budget was given to them with little or basically no feedback, and it was just a cost of living, for lack of a better term, an adjustment based on the prior year. People weren't adhering to those budgets. They were, in some cases, blowing through them with no recourse. And so one of the things I think that's helpful for us at going forward, once KPMG has their ability to work the processes and make sure everything's aligned appropriately, and so things are reporting back and forth correctly. I do think that having a budget for each, that the CEO has a budget for each different line of business and is meeting with them regularly so that they stay in budget. So that was why that criteria was added. Okay, any other thoughts on financial leadership? Okay, I'll type up some of these, and again, we'll let Ms. Lester distribute. Next area is quality. Maintain excellent patient care, excellent quality patient care standards, maintain a reliable, safe, and clean environment with working equipment, appropriately staff service lines in accordance with budget and annually assess needs. The measurement criteria of those objectives were elimination or timely address of serious safety events, reliability of faculty, address operational issues and needed procurement contracts quickly, get signed conflict of interest documents for all employees, board members, and contracts updated annually or upon renewal of the contract if a third party entity, have a written assessment of clinical needs and appropriate staff levels to fill those needs and reviewed semi-annually at least, continued employment of key associates, ELT and director level, specifically targeting a low turnover, excluding retirement and relocation, and improve leadership team relations and development by ensuring meaningful and challengeable goals, semi-annual performance improvement, meetings and goals, and developing future leaders. Dr. Elders, just curious as to your thoughts on this criteria with regard specific to quality.
Yeah, when I looked at the quality criteria, I truly feel like we have a means to demonstrate the measurement criteria. You know, I didn't necessarily feel that way about the financial section. Looking at all of the turmoil we're kind of in with our financial infrastructure, but for the quality, you all get a quality scorecard. There are data metrics that we can pull and demonstrate evidence of doing these things. For the signed conflict of interest, that's a report. Written assessment of clinical needs, that is something that can be demonstrated that I feel like can fully be demonstrated. It's not just a kind of a broad criteria as well as the other two.
Is that specific turnover metric seem like the right number? I have no sense for what like a standard turnover would be or anything like that.
I think maybe for this year, because what I'll be honest with you, with the transition and changes, we could say 10%, but losing 10% may not be a terrible thing, in all honesty. And so we may need to just, you all may need to just think about what that number looks like. For nursing, it's an 18% turnover that we strive for. In a clinical environment, it's 18, and so we're doing good there. So you may want to, elevate that just a little bit, and then, as you all discussed, as you look at additional years, you can tighten that up because that's, there'll be more stability after that.
Okay. Any other discussion around quality? Customer service. Provide excellent service to all patients. Create and maintain an excellent culture for employees. Also physicians. Provide confidential resource and process for employees and physicians to receive feedback and complaints, as well as a culture of compliance. The way we achieve that is exceed HCAP scores at 80% or better for fiscal year 24, because it's a delayed year, right? Okay. It should be 25. Okay, all right. Press Ganey employment engagement service of 4.11 or better, which is what was on the Press Ganey report that we received is where we should be with natural growth. Press Ganey engagement survey results of greater than 50%, meaning 50% of, greater than 50% of people actually fill them out, which has been a problem. Employee retention rates, this is, again, kind of the conversation with Dr. Elders, who had commented around is that the right number with some of the restructuring that's happened. So we may need to amend that or table it for this year and then, reinstate at a later date if we feel like the restructuring will supersede some of the need for these this year. Exit interviews for, we said 85% of employees and physicians completed with a follow-up process and monthly reporting to the board, which my understanding was not happening. And then I understand it kind of was happening, but kind of sporadically. And I think with any institution, you understand why people are leaving. And that way we can get that feedback. If we see trends, we can potentially make a different or better decision around what the issues are if we see them on a regular basis. And consistent and effective employee communication, which I know Dr. Elders has had many town halls and is proactively submitting memos out to the employee base to make sure that they are kept in, good stead with their knowledge about what's going on, the changes. Any other thoughts or changes here in this area of customer service? Yes, ma'am.
A clerical suggestion on the first one where it says scores for fiscal year 24. Could you just say that for the prior fiscal year or something, so that way we don't
Yeah.
have to update it each time and
That's-
remember
That's
to update
great.
it.
Great point. Anything else on customer service?
Dr. Elders, are you comfortable with these numbers that are here under customer service?
Yes, sir, I reviewed them and absolutely. Again, the retention rate in regards to the employees, if we, it may be just a language amendment because I think less than 15% is good, but then how we run that number at the end of the year would be important. Because this says exclude individuals for retirement age or relocation. We may want to add restructure or some other language in there because we've had to do that too, and you wouldn't want that to count against that person if that calculation's not clear. Thank you.
Dr. Enzerate, let me call on you if you don't mind, since you are a practicing physician. Is there anything in here, because, whether it's quality or customer service, you're front-facing to this. Is there anything that you feel like would be additive or we need to amend the language or if maybe there's something we're not addressing?
No, I think the metrics you have are great. Patient satisfaction, that's a universal. Every hospital in America uses that. And then the ones on retention. And yeah, I think those are good parameters.
Good. Okay. Last category is board member and stakeholder relationships. We greatly expanded this category, I know, on some of our committee members' recommendations. So keep hospital board informed of new growth initiatives, service line development, and any other issues that may impact the hospital's sustainability, growth, finances, or public profile. Maintain and grow relationships with stakeholders, city officials, medical schools, including Meharry, and community partners focused on building the brand and strengthening partnerships with NGH. We measure that by meeting with new board members within the first 30 days of appointment, meeting with board members quarterly to semi-annually, depending on the board members' needs and availability. Seeks community partnerships in Davidson County to maximize resources and have the impact on the greatest community health needs. Work with the NGH Foundation, development staff, and foundation board to implement a fundraising program that sets and meets established goals and establishes relationship with prospective donors and maintains those. I'll go again to you, Dr. Elders. Anything on that?
No, when I look at these are very key to the future and success of Nashville General Hospital. And so I looked at the goals and objectives, agree totally, as well as the measurement criteria. Any new CEO, especially if they're relocating, would need help with establishing relationships with prospective donors. But that could be, we're leaning in with the work with the foundation. That would be the only one that I would be a little concerned about. But other than that, they all look great.
Any other committee member recommendations? At the very end of the different 5 categories, the specific bullet points allow for the CEO to make comments. And it says, identify any achievements or contributions not already addressed above. Note any major accomplishments you believe should be recognized and provide background information. And then how can the hospital authority board help you most? I think these are great ways for someone to add comments that are maybe important to them. I don't know if there's any other bullet points. We don't want them to necessarily feel like they have to write an essay. But at the same token, I think this allows a little extra dialogue that would be helpful, hopefully, to us. But if you have any other recommendations on adding bullet points or amending the language, let us know.
Dr. Elders, any thoughts on that?
No, sir, these are great. I think if you're self-evaluating these based on the goals and objectives, you're already providing information. And so those just two questions just encompasses what you haven't already covered. So I don't think we need to add anything. Thank you.
I have a question not about that, but another part of this form, which is there's a weighted percentage that is assigned to each category, and they're currently all at 1. What's the function of that, and what do we need to do with that part?
Yeah, so we do need to amend the form and actually write out the scoring criteria that we had established in the past. I had talked to Derek, our legal counsel, about that, and he said as you continue to evolve the form, it would be helpful to have that written as part of the form for legal purposes. The weighted percentage in the past has been, do we provide that do we believe that 1%, this is the way it's been done, I think, in the past. Did they meet that criteria? And they got 1% if they did meet that criteria, for a total of up to 5%, which allowed for that person to have a full 5% of their bonus. But I think that, again, the way we had amended the language to allow for a point totaling comparative to just did you meet it or not, especially with all the different measurement criteria, it was confusing to me, which is, let's say someone got a 2, do they get 1% or no? If they got a 3, that's even harder. Do they get 1% or no? So I think what we did in prior board meetings was we created a scoring criteria that allowed us to provide a score between 1 to 5, calculate that, look at a range, and then that drove the 1 to 5% rather than this. So we just need to amend the form to where that makes more sense. Yes, ma'am.
Can I also make a suggestion? And I'm just going by my practice as a leader, when I evaluate my staff or those that report to me, any of them, 3's good. Like, we look at them and we talk to them, and 3's good, because if you look at performance of any human individual, there's always room for improvement. So if you all may just want to just play around and think about what that 1 to 5 actually means, because I do like 5 consistently exceeds, but then 3 is good. So we in the healthcare environment, getting a 3 means you're doing the job that you need to be doing. You're performing at your expected state. So it's like 3 for us is meeting expectations. And so right here it says average. Average to me, average is a negative connotation. 3 is a good, you're doing your job. Does that make sense? And typically what I have staff do, if you are given, you're rating yourself as a 4 or 5, you got to tell me how you're exceeding, not just meeting. And so I just maybe if we use 2 is developing. They're developing the skills to do that, or they're developing the processes to, so it's not just negative.
So what word would you use instead of average? Good?
Meeting expectations.
Meeting.
Because see, if you got 4, you're saying at 4, you're saying they're exceeding expectations. And then 5, you're saying they're consistently exceeding. Now, we use 3 as meeting expectations. They're meeting their job functions and criteria. 2 needs improvement, that's fine. 1, you might want to, because to me, it's, for somebody coming in, this is negative first year of employment. Right. So it's just something for you to think about. I like for 3 because I always share with my team that 3 is good. And so even, people take evaluations to heart. and I've had people cry getting a 3, and I've had to explain to them that 3 means you're doing what you need to do. And so just think about how you interface with the person that's coming in when you're talking about goals, especially them being new to the organization or new to the seat. 3 means you're doing the job you need to do.
Dr. Elders, is that a healthcare cultural?
Yes, sir.
Okay, because in general business, a 3 is, you better do better next year.
No, and really it comes from a environment of pay for performance, and it's something that I know that we want to look at, and I'll just glean on my experience from another health organization. What you do is you take your dollars, and in that bucket, I say for all employees, people that get a 3 get this percentage. People that get a 4 get this percentage. People that get a 5 get this percentage. It's to drive performance. And so 3 is not bad, but that what you want that CEO striving to do is a 4 or 5, which they're not going to do year 1 of employment. I'm just being honest with you all because I'm here. And so just as you're interfacing, you want to make sure this isn't a negative thing, especially in a public environment. And so I just think about that, because I know you all brought that concern up too, evaluating a person in public. And so what that means. 3 means like you said, in business, it means you better do better. In healthcare, you're doing your job, because it takes a lot to do a 4 in healthcare. It takes a lot to do a 5 in healthcare. Does that make sense?
So in the hospital system that I worked with in Las Vegas, so they did 3: Dignity Health and Common Spirit. Yeah, 3 was meets, 4 exceeds, and 5 was consistently exceed. That was similar to what Dr. Elders is describing, but that's just Common Spirit or Dignity Health is a faith-based organization.
Do you feel the same way about a 3? Do you feel like 3 is a good thing? Like that's what people should be at? No, I mean, but just like.
You want to be worried if you're below 3. If a 3 means that you're meeting expectation, it also means if you want to say you're performing, that you have to improve beyond 3. It just says you're meeting the job description. 4 means you're exceeding what's expected of you, and 5 means you're consistently exceeding. But this is just Common Spirit Health. 122 hospital systems.
No, I think it's very helpful to understand kind of culturally what that looks like and how it's different. I mean, it's in my organization and investment management, you're getting a 3. I mean, I get a 3 every year out of 5. It doesn't matter if I hung the moon and I was like the number 1 in terms of bringing new money into the firm. They will still give me a 3, which I think is crazy too. But I just know that that's what I'm going to get. You only, if your compliance problem, you might get it does not meet. But from a standpoint of, I even asked, I said, how do I get a 4 or 5, right? So I think it's about having a conversation and being able to understand. I have no problem with being a self-starter and obviously self-motivated, but at the end of the day, let's also be thoughtful about like not putting things out there that are completely unachievable. And so I think that's the real conversation here, which is, if someone's getting Employee of the Month or, in their line of business getting accolades, then they should probably get a 4 as an example in that category. And then that precedes the conversation of like, is there let's call it a bell curve or some kind of standardization by which we are looking at X percentage of the population is probably going to be 80% in a 3 anyway. So, and ones are on a PIPS plan. So, I think that's a bigger conversation. I do want to also mention that with regard to having multiple conversations with Dr. Elders, her style of, I think, performance ratings and engagement are very different than has been. I'm looking forward to that opportunity for her, if she's still in those roles, to continue to do that when at the appropriate time. We're looking at with this also calls, to me, is calls to look at other employees all across the full strata of the organization and make sure people are being paid appropriately. And then we can look at pay for performance and how we might institute that if that makes sense. So, the first step is, are we paying people correctly and hiring the right folks to take a look at that? And I think they're working on that as we speak. I think that's an important piece. So that's just maybe a little insight and update. So it's a bigger conversation too.
And I wouldn't mind, because as I will be out tomorrow, a pre-plan prior to any of this last year, so I will not be at the board meeting tomorrow, but I do want to let you all know we did hold a town hall in regards to salary increases, which we have put on hold for now, while we do the compensation and job structure review across the organization, as well as finish up the financial infrastructure reset with KPMG. Two contracts that you'll see tomorrow are from UKG, which is our timekeeping system. They also have the entire employee package, which will replace some of our human resources tracking and separate systems, and will give us the package to where we can move to a pay-for-performance structure at some point in time. And you all will be seeing that tomorrow. And Diana will be there, as well as Dr. Blackish, to speak on those things. But I just, since I had the mic, wanted to share. Thank you.
May I, Madam Chair, bring up two things. One, I was here yesterday and sat in on Dr. Elder's conversations, not just with the senior team, but with all the employees. And I have to tell you, she'd get a pretty high ranking on being transparent and saying it like it was in a very positive way to employees. And it was very impressive, much appreciated. But the other piece, and going back to our issues here, I understand the cultural connotation of a 3, and I'm fine with changing average to meets. But I also want to keep it in the context of what is the tone of what we are trying to do now, in that we are trying to be exceptional. And aiming for exceptional means meeting expectations doesn't quite bridge the gap. And so I hope as we proceed, we can make sure that we keep all of that in mind, that particularly from the CEO perspective, a 3 in my mind would not be something I would be particularly proud of.
Oh, absolutely. I'm just thinking first year for that individual.
I understand.
I'm just thinking
and I
first.
don't want to go back and forth. I
Yeah,
understand your
yeah,
point, and
yeah.
I appreciate it.
Yes, sir. Yes, sir.
Okay, any other further comments on the assessment form? Okay, seeing none, I'll work with Ms. Lesser, and we'll get these typed up, and then we'll distribute. And then at that point, if there are further comments, the next step will be to implement the changes into the form, send the form back out, and if, have another opportunity to review it in the actual format. And then the goal would be to be able to move that to the full board for approval for fiscal year 26, knowing that it will be a continual evolution, and especially with KPMG finishing up their information, we'll be able to feel more confident about and probably further refine these goals. Okay, thank you.
Do we need to schedule another meeting?
Good point. The question I would have is, do we need to, I guess we would need to probably meet to move to full board, yeah.
And then recommend to the full board.
Do we?
And we don't want to wait 3 months for that.
Right, so do we think that needs to happen in July or August? What do you think?
The sooner the better.
Okay.
To get it past us, and so that the CEO can know what that year's expectations are.
Would it make sense to potentially have this meeting prior to the finance committee meeting prior to the board? And do them back to back to back and have them the same day?
July
Correct.
31st. July 31st.
Does that make sense? Or do you recommend doing it the day before or another time? Go ahead.
I think that's a great suggestion, and I wouldn't allocate a full hour for it. I
30
think
minutes?
at most,
Right. I could just do a 30 minutes.
because it,
And then we have time for the team to transfer over to the finance committee.
Yeah.
Because it takes them a minute.
I mean, I think we are to the point where.
Yeah,
we're
we're almost
have-
there.
We can review the next round of edits and be pretty confident that we are at the
That would
conclusion.
be, the recommendation to the full board would be when?
Oh, you're right. It would be, we could do the same day as long as there's not something that any documents they need 7 days prior. I don't think, a verbal report should work. Right?
And we should have the finalized document by that point, so we could submit it.
Actually, I could go ahead and put the document as we have it 7 days prior in the packet.
Perfect.
And then you give your report and get the approval.
There's
So
any-
the
that
full
work?
recommendation and vote can be at the July board meeting. And we
Right.
can get it behind us.
I
Correct.
believe that would work. So that means our document needs to be finalized by, say, the 23rd.
Correct.
Right, it would be finalized. The board would have a copy of this assessment
That
form,
Correct.
subject to whatever, it's either going to be ratified at an hour before the board meeting, or there will be some revisions, and we can explain to the board, I think,
Absolutely.
that the materials that you receive were recently amended in the following X number of ways, and the board could vote on that.
I believe that would be correct.
Okay.
So we will go with 2:30 on July 31st as the next meeting, and I will send the posting this afternoon.
Okay, great. Any other business to discuss? Seeing none?
So moved.
Second.
Great, thank you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov